Small vessel vasculitis. We classify vasculitis according to the size of the vessels that are involved. This allows to group diseases by similar clinical presentation. In fact, as we said, the clinical presentation changes according to the size of the vessels. Many symptoms are shared by vasculitis of the same family, although being different diseases with different pathogenesis and prognosis. Example, inflammation of the aorta gives aneurysm or stenosis, while inflammation of the small vessels gives hemorrhages. So small vessel vasculitis can be divided into categories of disorders on the basis of two main pathogenetic mechanisms. A vasculitis associated with immune deposits, like essential cryoglobulinemic vasculitis and IgA vasculitis, like Enoch, also known as Enoch-Schonlein purpura. We have also anche associated vasculitis, such as granulomatosis with polyangiitis, also known as Wegener granulomatosis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis, also known as Churg-Strauss syndrome. We have hypersensitivity reactions that are classified into four different types. Type 1 IgE, it's an extremely rapid and fast response in minutes. Antigens cross-links IgE on mast cells and basophils, which causes a release of vasoactive biomolecules. It is responsible for allergy. Type 2 cytotoxic, antibody-dependent, is dependent on antibody formation. The antibody IgM or IgG binds to an IgG on a target cell, generating inflammation and cellular destruction. The two main determinants of this reaction are the complement MAC formation and antibody-dependent cell-mediated cytotoxicity. Type 3 immune complex and polymorphonuclear cells have antibodies IgG which bind to a soluble antigen, forming a circulating immunocomplex. Immunocomplex precipitates in different tissues, causing complement activation, local inflammatory reaction. What occurs is lysis of the cell in which the immune complex has precipitated, and formation of complement intermediates which have a chemotactic effect on cells, mainly polymorphonuclear cells. Polymorphonuclear cells infiltrate and are responsible for further inflammation of this tissue. Type 4, T-cell mediated, is a classic T-cell mediated reaction, such as delayed type hypersensitivity reaction. T-cells find an antigen and activate macrophages. So, vasculitis associated with immune deposits. This group of diseases is a consequence of type 3 hypersensitivity reaction. Have serum sickness, also known as Arthur's reaction, which is the prototype of type 3 hypersensitivity reaction. It was discovered after injection of horse serum into a rabbit. Antibodies in the rabbit were able to bind antibodies present in the horse serum because they recognized them as foreign antigen, and the immune complex will be forming. There will be complement activation and thrombosis in the small vessels. This usually causes problems, especially in joints, kidney, skin, and peripheral nerves. Fever and general symptoms will also occur in the animal. It is not immediate, but occurs after a few days, typically 10 days. It occurs formation of immunity against the new antigen and formation of immune complexes. When immune complexes start precipitating, the disease is in maximal activity. Then the phagocytic system will be clearing up the immune complexes, leading to resolution, with the formation of long-lasting memory against the foreign antigen. Immune complexes precipitated in tissues can be detected through immunofluorescence. Both complement and the different subclasses of antibodies can be stained. In this way, you are able to determine which kind of process has occurred. When you ask a biopsy suspecting vasculitis, you should give specific information to the surgeon and to the pathologist in order to properly preserve the tissue from immunofluorescence study. Usually, the surgical sample has not been immediately fixed in formalin, but put in normal saline solution and fixated only after some samples for immunofluorescence have been taken. So, cryoglobulinemic vasculitis. Cryoglobulins are proteins that precipitate at low temperature less than 37 degrees, so they normally do not precipitate in the human body. The disease will be more severe if the precipitating temperature is higher. They are typically mono or polyclonal, mainly IgM, IgG, and IgA. The determinants of precipitation are concentration of the protein, chemical-physical properties of the protein, the possibility to bind complement. Precipitation is irreversible. Once protein have precipitated, it is impossible to revert the process and to analyze the proteins. Therefore, when you draw blood from the patient and you want to know if the proteins are present, you have to keep the tube warm, put it into hot water and take it to the lab as soon as possible. Remember that not always the precipitates are immunoglobulins. For example, there is a disease called cryofibrinogemia, characterized by the presence of a specific genetic variant of fibrinogen that precipitates at low temperatures. Cryoglobulins have been classified into three classes according to the antibodies that are involved in the process. The classic form of cryoglobulinemic vasculitis, the one that we are describing today, two antibodies are involved, class 2 and class 3 cryoglobulinemia, whereas another class, class 1, which is not immediately connected to autoimmune diseases, is characterized by just one antibody. We have class 1 cryoglobulinemia, where we have just one antibody, which is typically monoclonal, either IgG or IgM. This single antibody may precipitate if it is exposed to low temperatures. This is rarely present in vasculitic syndromes, but is more common in hematological malignancies, like multiple myeloma or Waldenström macroglobulinemia. Waldenström macroglobulinemia is a monoclonal proliferation of cells which produce IgM. One of the main problems of patients with Waldenström macroglobulinemia is hyperviscosity due to the increased number of IgM, whereas they rarely develop vasculitis since IgM do not fix well the complement. Since complement activation is one of the main determinants of diseases in vasculitis, if you don't fix complement, you don't have vasculitis. The main problem of these diseases is hyperviscosity, and the situation is worsened by the fact that these immunocomplexes may precipitate in small vessels of the extremities, causing thrombosis. Then you have class 2 and class 3 cryoglobulinemia. Immunocomplexes are created. In both cases, there is an antibody which acts as a rheumatoid factor plus another antibody. The rheumatoid factor is an antibody, more commonly an IgM, that is directed against the crystallizable fragment of another immunoglobulin. Actually, it's an antibody that is specific for another antibody in its Fc determinant. F class 2, which is a polyclonal antibody, an IgG, and a monoclonal antibody, an IgM, which has a rheumatoid factor function. It is typically found in infective diseases, especially in HIV-positive individuals, but it may also occur in connective tissue diseases, 10% of cases, such as Sjogren's syndrome, SLE, and rheumatoid arthritis. 90% of these cases are due to HCV infection. A huge number, more than 50% of patients with HCV infection has cryoglobulinemia, and 1/4 of them has some cryoglobulinemic manifestations. Class 3, both antibodies, the rheumatoid factor and the antibody that is recognized by the rheumatoid factor, are polyclonal. It is more commonly found in connective tissue diseases and frequently, but not always, also in infective diseases. These two classes, 2 and 3, are referred to as mixed cryoglobulinemia. There are different antibodies, typically an IgG and an IgM. When mixed cryoglobulinemia is not associated to a connective tissue disease or an infection, the disease is called essential mixed cryoglobulinemia. HCV association with cryoglobulins. HCV has a specific tropism for receptor CD81, which is responsible for entry of the virus into hepatocytes, but it is also expressed by B cells. The binding of HCV to B cells through CD81 lowers the threshold for activation of these cells, making them more active. Being more active, they proliferate monoclonally or polyclonally and eventually produce antibodies. This is one of the reasons why significant Hypergammaglobulinemia occurs in HCV-positive patients. Chronic infection causes chronic production of IgM, and this stimulates the immune system to produce more rheumatoid factor to clear the immunocomplexes. This chronic stimulation is responsible for development of B-cell lymphoma in 10-20% of patients in 10 years. So this is a picture depicting the two possible rheumatoid factors: IgM towards the IgG, or IgG towards the FC portion. Since the result is immunocomplex formation and the immunocomplex is very good in fixing complement, they are able to start a vasculitic process. Vascular changes is caused by the position of immunocomplexes that are able to fix complement and determine inflammation. Since complement activation is able to release a number of factors responsible for polymorphonuclear cells recruitment, there is both a direct damage to cells by complement and infiltration of polymorphonuclear cells. In some cases, more typically in type 1 cryoglobulinemia, there may be physical obstruction on the small vessels due to increased viscosity of the blood. This is not only due to the increased number of antibodies, but also due to their precipitation in the peripheral small vessels where the temperature is lower. So as said, we have type 1 in 10-15% of cases, no rheumatoid factor, and monoclonal antibodies IgM or IgG. Associated diseases are hematological malignancies, multiple myeloma, the strong macroglobulinemia, rarely cause vasculitis because they don't fix complement, and we have hyperviscosity. Type 2, 60% of cases, we have presence of rheumatoid factor, we have presence of polymono IgG and mono IgM associated with HCV and other infections. Instead, type 3, that is present in 25-30% of cases, we have rheumatoid factor association, no monoclonal antibodies, only polyclonal IgM and IgG, and the associated diseases are mainly systemic sclerosis, lupus, and rheumatoid arthritis. So the clinical presentation is, we have a classic triad, which is purpura, arthralgia, and myalgia fatigue. There is not only inflammation of the small vessels, purpura, but also a systemic inflammation, arthralgia and fatigue. These symptoms are extremely aspecific, but when they present together, you have to think about this disease. Other manifestations are membranous proliferative glomerulonephritis, GI involvement, and polyneuritis, mononeuritis multiplex. Every single organ can be potentially affected, although it's more common in those organs having an extensive number of small vessels, like the kidney, and those particularly sensitive to acute hypoxia, like the nerves. The skin is the most common manifestation of the disease in 80% of cases, and the one that can be more easily inspected by doctors. At histological appearance, we have an inflammatory reaction in the vessel wall with infiltration by polymorphonuclear cells. We have palpable purpura, which is caused by blood leakage and infiltration of leukocytes. Macroscopically, we have a mix between an urticarial reaction and hemorrhages. The lesions may coalesce together, forming plaques. It differs from thrombotic thrombocytopenic purpura, where lesions are darker and more hemorrhagic. You can have also digital ischemia and gangrene, because cryoglobulins prefer to precipitate at low temperatures, and clearly the extremities are more exposed to lower temperatures with respect to the rest of the body. Have also ulcers, which occur in case of vasculitic lesions in areas of the skin which are exposed to high tension. They are difficult to heal and may give severe infectious complications. We can have also livedo racemosa, which is larger than livedo reticularis, which is typical of middle-sized vessel disease. It appears as a whitish area mixed with large flat reddish discolorations, giving irregular spot-like appearance. Livedo reticularis is the term used to describe a net-like mottled or reticulated pink or reddish-blue discoloration of the skin, mostly on the extremities, especially the legs. It's more prominent with exposure to cold and may vanish with warming. It is commonly seen on the lower extremities in young children and women. The pathogenic basis is reduced blood flow through and lowered oxygen tension in the venous plexus of the skin. Livedo racemosa forms irregular networks and broken circular segments that are fixed and do not vary appreciably with temperature changes. So, neuropathy. We have polyneuritis and mononeuritis multiplex, which is a painful asymmetrical synchronous sensory and motor peripheral neuropathy involving isolated damage to at least two separate nerve areas. Multiple nerves in random areas of the body can be affected. As the condition worsens, it becomes less multifocal and more symmetrical. We have also glomerulonephritis, which is a typically membranoproliferative glomerulonephritis. Biopsy shows deposits of immunocomplexes and a complement. When you analyze the glomerular damage that is mediated by the immunocomplexes, you may have a number of different damages, and the biopsy could reveal a different distribution of immunocomplexes depending on the disease. If the immunocomplex has a high molecular weight and is negatively charged, it won't be able to cross the glomerulus, therefore it stops in the subendothelial layer, forming subendothelial deposits. This is typical of mesangial-proliferative glomerulonephritis, which is typical of cryoglobulinemia, huge immunocomplexes made of IgM and IgG. We have also intramembranous deposits, which are typical of Ghost-Pasteur syndrome. It's characterized by antibodies directed against the basal membrane, the typically fixed complement, causing inflammation and hemorrhages at the alveolar and glomerular level. We have also mesangial deposits, which are the pathogenic findings of IgA glomerulonephritis, and subepithelial deposits of small and positively charged immunocomplexes which are able to deeply penetrate the glomerulus. It is typical of acute proliferative glomerulonephritis. At histology, we find a tram-track appearance of thickened basal membrane as consequence of deposits. The immunofluorescence, we have deposition of immunocomplex and complement. We can have also Zika syndrome, which is inflammation of small vessels in the salivary and lacrimal glands. We have also GI involvement, which is a vague abdominal pain not associated with feeding, which is different from large vessel vasculitis, where we have claudicatia abdominis. Pain is a consequence of increased blood requirement by the gut, for example after eating. So, vague abdominal pain not associated with feeding and positive occult blood in the stools. We have also an increased risk of B-cell lymphoma, especially those related to an increased production of rheumatoid factor due to prolonged increased stimulation of B cells. So, the manifestations are in the skin, palpable purpura, livedo racemosa, ulcers and digital ischemia and gangrene, infiltration by polymorphonuclear cells. We have polyneuritis and mononeuritis multiplex, membranoproliferative glomerulonephritis, Zika syndrome, GI involvement not associated with feeding, and increased risk of B-cell lymphoma. Lab findings are increased ESR, neutrophilic leukocytosis, rheumatoid factor positive. It can turn negative if it precipitates with the cryoglobulins. Remember to keep the tube of the blood in hot water before and while taking it to the lab. We can have also cryoprecipitates and a reduced level of complement, especially during the acute phase of the disease. C4 is more reduced than C3. Can have also we then have IgA vasculitis, which is the most common vasculitis of the child, although it can also happen in adult life. It usually occurs after an acute viral, sometimes also bacterial illness, classically affecting the upper respiratory tract. Normally this disease is benign and self-limiting without specific treatment, but as the kid grows up and in adults, the disease may be more severe, especially for the kidney involvement. In adults, it may progress and can have a significant overlap with IgA nephropathy and Bessy disease, which is a cause of chronic renal failure. In children, this is a typical hypersensitivity reaction toward an antigen presented during the infection. In adults, it's more commonly due to a hypersensitivity reaction against something foreign like food or drugs. The diagnosis is based on the clinical presentation and skin biopsy. So, polymorphonuclear cells infiltrate. At immunofluorescence, we have IgA deposits. Pathogenesis, we have immunocomplexes formation. So, the antigen is the viral antigen drug, and the immune antibody is an IgA. Deposition, immunocomplex formation, deposition in the wall of small vessels, and activation of complement. Labs tests are generally normal, although you may find a slight increase in the inflammatory indices. Normally, serum IgAs are increased, probably representing the effect of an impaired glycosylation. IgA glycosylation is one of the determinants of the fact that IgAs are normally sent to the external part of the body, so tears and gut. Usually in healthy patients, low levels of IgA are found in the plasma. If you have problems in the glycosylation, you will have problems in trafficking IgAs, which will go more deep easily to the plasma and possibly cause this type of reaction. Clinical manifestations are extremely specific. In kids, the presentation is with fever, palpable purpura in almost 100% of cases. It's required actually for diagnosis. It is more inflammatory in type, so it's urticaria-like with respect to purpura typical of cryoglobulinemia. It is usually located in the buttocks, back and limbs. We have also arthralgia with typically ankles and knees, not migrating, which means a joint is affected and pain won't move to another joint. It is remitting spontaneously. You can have also testicular or scrotal pain. You have GI involvement, which is quite frequent. Colic abdominal pain occurs in 80% of patients. There is the possibility of intussusception, which is a medical condition in which a part of the intestine is invaginated into another section of intestine, similar to the way in which the parts of a collapsible telescope slide into one another. The pressure present in the site of insertion may cause ischemia and consequent necrosis of the gut. We have also micro or macrohematuria and glomerulonephritis usually in older kids. It typically presents months after the onset of purpura. In adult, the clinical presentation is with purpura, arthritis more than arthralgia, less frequently abdominal involvement. A good number of patients develop glomerulonephritis, which may evolve to IgA nephropathy with less favorable outcome. Mononeuritis and polyneuritis multiplex occur in 10% of cases in 10% of the patients. In adults, it's more often associated with reaction to drugs than to infections. Classification criteria are palpable purpura, age at onset of less than 20, acute abdominal pain, biopsy showing granulocytes in the walls of arteries and veins. They are extremely specific and they are not immediately used in the clinic. For example, there is no mention to IgA. So here we see that palpable purpura, 100% of cases. Arthralgia arthritis, non-migrating spontaneous remission in 80% of cases. This is in the child. And scrotal testicular pain in 38% of cases. Also abdominal pain with blood in stools, colic type of pain in 80% of cases, intussusception occasionally, and glomerulonephritis in older children in 50% of cases. In adults, purpura arthritis, less frequent abdominal involvement, fever, not always, and glomerulonephritis. So, ANCA-associated vasculitis. There are necrotizing vasculitis with few or no immune deposits in the vessel wall. The three major diseases are granulomatosis with polyangiitis, also called Wegener's granulomatosis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis, also called Churg-Strauss syndromes. ANCAs are autoantibodies directed against cytoplasm of neutrophils. More specifically, they are directed against enzymes contained in alpha granules. They can be detected by immunofluorescence and are subdivided into cyanca if they have a cytoplasmic appearance at immunofluorescence. Their specific antigen is protein is free. Pianca if they have a perinuclear appearance at immunofluorescence. Their specific antigen is myeloperoxidase, MPO, but they also recognize other antigens. They are less specific for vasculitis since they cross-react with other enzymes contained in the alpha granules of polymorphonuclear cells and other cells. The cytoplasmic and perinuclear localization of the two subclasses of ANCA is a sort of artifact induced by the fixative used in the lab for staining. In fact, if you don't separate them, okay. So, ANCA positivity is present in 80–90% of cases in GPA, 70% of cases in eGPA, and 50% of cases in MPA, microscopic polyangiitis. ANCA antigen specificity in GPA we have much more prominence of PR3, so cyanca. In eGPA we have mainly pianca. In MPA instead, and also we have mainly pianca. So pathogenesis. Antibodies anti-PR3 and anti-MPO recognize their specific antigens expressed on the surface of polymorphonuclear cells and activate them. This causes activation of endothelial cells, which in turn can produce the same enzymes, PR3 and MPO, that are contained in the polymorphonuclear cells. This results in endothelial cells being attacked by ANCA antibodies, since now they also express PR3 and MPO. Autoactivation through the Fc receptor of polymorphonuclear cells. They secrete reactive oxygen species and chemokines, inducing inflammation of the endothelium and creating local damage. In this reaction, autoantibodies are present on the cells. There are no deposits. If they are present, they are minimal and they are soon phagocytosed by the polymorphonuclear cells. Microscopic polyangiitis is a systemic disease, whereas granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis are typically preceded by months, years of granulomatous inflammation, so prevasculitic phase, that preexists to the development of the systemic vasculitis. We have a prevasculitic phase. In granulomatosis with polyangiitis, you have an inflammation of the upper and the intermediate respiratory tract, mainly sinusitis, otitis, and rhinitis. It can be accompanied by dyspnea and, in case of lung inflammation, respiratory insufficiency. This clinical presentation, granulomatous inflammation with mid-line obstructive lesions of the upper airways, may also occur in cocaine abusers. Cocaine may be sometimes associated with granulomatosis with polyangiitis, but is something that you should really consider as differential diagnosis for destructive midline lesions. Cocaine is also able to induce ANCA, unknown reason. Histology, we have necrotizing granulomas with neutrophil and macrophage infiltration. They have high destructive power, therefore they almost always invade surrounding structures. Invasion can cause very severe damage, so leading to surrounding structure of sinuses are the brain and eyes, in fact. This very severe damage is because the surrounding structures of sinuses are this brain and eyes. At X-rays, we have fixed granulomas, which remain stable over time. Eosinophilic granulomatosis with polyangiitis. Here we have an history of asthma, allergic rhinitis, and nasal polyposis. At histology, we have granulomas with eosinophilic infiltration. The destructive power of eosinophils is much less than the one of neutrophils. and macrophages, so granulomas quite rarely invade and destroy surrounding tissues. They more commonly fill cavities. At X-rays, they are less fixed, so sites of consolidation change over time. The initial inflammation resolves without damaging the lump parenchyma. This presentation is induced by antigens. At granulomatosis with polyangiitis, we have a staphylococcal infection. In fact, treatment with antibiotics that are able to reduce the staphylococcal load is able to reduce the risk of relapse of disease. We have also cocaine and metals and drugs. EGPA, we have allergens as one of the main determinants. In fact, is typically associated with asthma. ANCA are less prevalent in the prevasculitic phase. For this reason, it is even more difficult to diagnose this disease in this phase because the number of patients that are ANCA positive is lower. Consider that some GPA patients won't develop vasculitis but will remain in the prevasculitic phase. These patients are more typically associated with huge destructive lesions. Patients that remain in the prevasculitic phase can be diagnosed through a biopsy, which shows granulomatous reaction with deposition of macrophages and neutrophils, mainly in the upper respiratory tract. Glomerulomatosis with polyangiitis is a multisystemic disease of unknown etiology, characterized by granulomas of upper and lower airways, glomerulonephritis, and necrotizing post-immunovasculitis. Biopsy, in fact, shows leukocytoplasia. Polymorphonuclear cells enter the vessel wall and destroy the tissue, but there is no evidence of immunocomplex deposition. Typically, there are a number of destroying inflammatory necrotizing lesions in the eye, nose, throat, lungs, and kidney. Nerve, polyneuritis, mononeuritis, multiplex, and CNS involvement occurs in 1/4 of patients. They are associated to CANCA. Males are affected as females. It's more common in Caucasians than in blacks or other ethnicities. There is low prevalence in the United States. The diagnosis is easy when there are midline lesions of the upper airways together with glomerulonephritis. It is more difficult if the clinical presentation is atypical or incomplete. 7% of patients remain undiagnosed for years after presentation. The differential diagnosis is with cocaine abuse and infectious causes, so tuberculosis has a different histology of the granuloma. Clinical presentation: 80% of patients do not have granulomas. Do not have what? Okay. 80% of patients do not have glomerulonephritis. In 50% of patients, there is lung involvement alone. The disease follows a remitting relapsing pattern. You treat these patients with antibiotics, thinking about an infectious cause for the respiratory symptoms without an improvement. Then you turn to steroids, immunosuppressants, and patients respond, typically. So in the nose, we have mucopurulent bloody rhinorrhea. A typical finding is the saddle nose deformity. Since the granulomas are destroying the structure of the nose will collapse due to cocaine abuse. In the sinuses, we have mainly paranasal sinuses. They can be superinfected quite easily. They are a relevant cause of centrofacial pain. In the ear, we have otitis media or destructive lesion of the ear, which may occur. Larynx can be frequently affected. Symptoms are dysphonia and aphonia if the vocal cords are affected. Significant inflammation of the larynx may cause stenosis at the level of the glottis or subglottis, which may interfere with breathing. This condition is extremely resistant to systemic steroid or immunosuppressants. What has to be done in this case is mechanical dilatation of the trachea or local injection of steroids. In the eye, the retrobulbar space is completely occupied by the inflammatory material. The result is a monolateral, painful exophthalmos. There may be possible ischemic changes in the retina and optic nerve due to the compression of vascular or ocular structures. Inflammation can extend to other structures of the eye, such as the sclera, so scleritis, red, painful, and deep inflammation, and it's a medical emergency because if it progresses, it can cause tears in the eye. In the lungs, we can have infiltration nodules, which are present in 50% of patients. Only half of them have symptoms such as cough, hemoptysis, or pleuritis. One-third of them are completely asymptomatic, but lung involvement can still be demonstrated by CT scan or X-ray. Biopsy shows necrosis, vasculitis, and granulomatous inflammation. Some help can come from BAL and lung functional tests. Imaging shows consolidation, which gives a differential diagnosis with tuberculosis. Tuberculosis. Granulomas can undergo cavitation and excavation. When the granulomatous content opens and erodes the lung, it reaches a bronchus. The patient has cough and eliminates the material, leaving an empty space in the lung parenchyma, which can be quite easily colonized by bacteria. Kidney, it's a major odor, visual involvement. When they are involved, the disease is systemic. Otherwise, if only respiratory tract is involved, it is limited. There is an active urine sediment. It is the most predictive test in all active glomerulonephritis, together with the presence of microhematuria, so red blood cell casts. So active urine sediment and microhematuria is the most predictive test. When kidneys are involved, they are usually significantly affected, and the mean survival without treatment is 5 months. If treated, 42% of patients will develop still ESD, end-stage renal disease, 10% will be on dialysis, and 5% will need kidney transplant. The skin has the same manifestations we have seen in other small vessel vasculitis, so palpable purpura. On biopsy, no immune deposits are detected. Their neurologic involvement is the same that you can see in other small vessel vasculitis. The systemic manifestations are fever and weight loss. Tuberculosis and cancer remain the main diseases for differential diagnosis. Microscopic polyangiitis. So, polyarteritis nodosa is not associated to ANCA. Microscopic polyangiitis instead is associated to ANCA. It was actually different. They were thought to be the same disease in the past, but now they are divided. MPA is a multisystemic necrotizing vasculitis. Differently from GPA and EGPA, MPA is a vasculitis per se, characterized by small vessel vasculitis, but small vessel involvement, rarely medium-sized vessels. Immunocomplex deposits are limited and there are no granulomas. It's frequently associated with rapidly progressive glomerulonephritis and with pulmonary capillaritis. So we have a differential diagnosis with Goodpasture syndrome. It is much more rare. Hemoptysis and hematuria are more prominent. Antibodies against the basal membrane can be detected in the blood and in biopsy. It's quite easy to make the differential diagnosis, although the symptoms may be quite similar. At imaging, we have pulmonary capillaritis with a ground glass appearance. Capillaries bleed and the alveoli are filled with blood. Patients may cough blood, but is not so frequent since blood comes from capillaries and not small arteries. We can demonstrate that the patient has capillaritis through bronchoscopy and bronchoalveolar lavage. You can understand that the presence of red blood cells in the respiratory tree is not a consequence of the procedure, bleeding caused by the insertion of the bronchoscope, but is caused by capillaritis because you find a huge number of macrophages filled with degraded red blood cells. Clearance of red blood cells by macrophages is another reason why hemoptysis may be absent in these patients. So we have the differences between polyarteritis nodosa and microscopic polyangiitis are: polyarteritis nodosa, it's a necrotizing polymorphic infiltrate, rare granulomas. MPA, we have necrotizing, the same thing more or less, but granulomas are not present. In polyarteritis nodosa, the involved vessels are mainly small medium arteries, rarely arterioles, while in MPA we have arterioles, capillaries and venous, and rarely medium arteries. In the kidney, we have, in polyarteritis nodosa, renovascular hypertension. In MPA, we have proteinuria and rapidly progressive glomerulonephritis. Panarteritis nodosa, it's an acute onset, while an MPA is subacute chronic. PAN relapses are rare, while in MPA they are frequent. In PAN, we have arteriographic abnormalities which are absent in MPA. In PN, PANC is less than 10%, while in MPA, they're present in 50-75% of cases. Lungs are spared in polyarteritis nodosa, while in MPA there is 30% of infiltrates, nodules, and hemorrhages. Xenophilic granulomatosis with polyangiitis is a necrotizing vasculitis of small vessels, characterized by the formation of granulomas, mainly composed of xenophils. Which is different from granulomatosis with polyangiitis, where granuloma contains polymorphonuclear cells and macrophages. Here they contain eosinophils. There is peripheral eosinophilia with tissue infiltration, and usually there is a history of asthma, rhinitis, and polyposis. It's rare. Males are affected as females, and the onset is between 30 and 50 years. The precipitating factors are inhaled allergens, vaccination, and drugs, like macrolides and leukotriene inhibitors, and possibly the presence of IgE. For a long time, the medical community believed in an association between the use of leukotrienes inhibitors and the development of EGPA. Then a meta-analysis showed that there was a huge misunderstanding. Indeed, leukotriene inhibitors were used in severe asthma resistant to other treatments, so the population that actually was exposed to leukotriene inhibitors and then developed EGPA were the most severe asthmatic one. Okay, so the association between, pathogenesis. We have an activation of polymorphonuclear cells by antibodies, release of inflammatory cytokines and chemokines, which in turn activate even more the cells, activate the endothelium and cause damage to it. Some mechanism we showed before. At histology, we have infiltration of polymorphonuclear cells and eosinophils. Clinical presentation is typically composed of three phases. We have a prodromic phase with asthma, rhinitis, and polyposis. We have an eosinophilic phase with lung and GI infiltrates. We have a vasculitic phase with constitutional symptoms and systemic manifestations. Generally, they are in this order, but they may also overlap and become indistinguishable. Asthma and allergic rhinitis are necessary to make the diagnosis. In phase 3, the possible systemic manifestations are lungs, where we have less solid nodules than GPA, which resolve with time without permanent damage to lung parenchyma. Parenchymal nervous system. In the peripheral nervous system, we have sensory motor mononeuritis multiplex with areas of hyperesthesia or hypoesthesia. It's extremely typical of EGPA, much more frequent in EGPA patients than any other vasculitis of small vessels. It usually affects the lower limbs. Typical presentation is foot drop due to motor lesion. In the skin, the presentation is equal to any other vasculitis of the skin. At biopsy, eosinophilic infiltration without immunocomplexes deposition. Heart, we have an eosinophilic infiltrate which has a pro-inflammatory activity and alters the endothelial stability and may cause intramural thrombosis. It's not the first manifestation, but it may happen in 50% of the patients. EKG abnormalities are extremely common due to conduction problems caused by inflammation of the conduction system. Any structure can be involved, even coronary arteries. We have also GI and kidney involvement, where you have a focal proliferative glomerulonephritis, less aggressive than glomerulonephritis with polyangiitis. treatment is anywhere required, although the prognosis is better than granulomatosis with polyangiitis. The labs show anemia and increased ESR during the acute phase. If a patient has asthma and significant eosinophilia, more than 100 units per microliter, it's highly suggestive for a GPA, especially in the context of X-ray or CT showing infiltrates. 75% of patients have increased IgE and maybe MPO are ANCA positive. Angiographic studies are normal since the disease affects the small vessels. Imaging of ANCA-associated vasculitis. Summary. So at GPA, Wegener's disease, we have consolidations and excavating lesions. Excavating lesions are not present in any other small vessel vasculitis. The differential diagnosis is with cancer and tuberculosis. If you repeat the imaging studies after a couple of months during which the patient has not been treated, you will probably find the same lesions. At microscopic polyangiitis, we have capillaritis, so the alveoli are filled with blood. Imaging after a couple of months would show disease progression. The GPA shows faint irregular infiltration. Imaging after a couple of months would show other patch infiltrations in different locations of the lung with respect to the initial one.